So welcome to the Drug Price Transparency Stakeholder webinar for issuers and carriers. This is Lita Vasquez. I am the Northwest Prescription Drug Consortium Operations Manager and the project coordinator for this project. First, some rules on the webinar. This meeting is being recorded. Every time you speak, first state your name and what organization you represent. If you have a question, you have two options. You can type it into the question box and I will read it out loud, or raise your hand and I will interrupt the presenter and unmute you so you can ask your question. We want this meeting to be a conversation. Now, to introduce the Healthcare Authority members on the webinar, we have two presenters today. Annette Schuffenhauer, the Chief Legal Officer, who is on the Project Executive Steering Committee, and Donna Sullivan, the Chief Pharmacy Officer, who is the project lead. We have project managers, Arshina Hussain, who is a pharmacy data analyst, and Bob Swan, a project manager with the Planning and Performance Division. Members of the Executive Steering Committee, Mary Fliss, who is the Deputy for Clinical Strategy and Operations, and Michelle Needham, Chief Policy Officer. And we have work group members, Amanda Avalos, who's the Manager of Program Initiatives and Analytics, Matt Ackerman, the CQCT Communications, and Ryan Pistresi, Assistant Chief Pharmacy Officer. And now I'm going to turn it over to Annette. Hi, Annette, are you on? All right, maybe I will turn it over to Donna.
Hi, Lita, this is Donna. Can you hear me?
Yes.
Okay, great. So let's go ahead and we did the welcome and introductions. Lita went through some webinar instructions. It is audio recorded, so if you are speaking, could you please state your name before you ask your question or speak for the transcript so that we know who is asking which questions. So today, for the agenda, we'll go over the Drug Price Transparency Program. We'll look at the HCA's Rulemaking Schedule. We want to hear from you, so we have some questions that we're going to ask you. We also have some definitions that we will ask for your feedback on. And then we have contact information at the end of the presentation in case you have questions after the webinar is over, or if you have colleagues that want to submit questions that were not able to attend today. So next slide. So the legislature last year passed the Drug Price Transparency Program. So it is Chapter 43.71C of the Revised Code of Washington. It directs HCA to implement a drug cost transparency program. And there are really four stakeholders or submitter types that are listed here: the health carriers, pharmacy benefit managers, drug manufacturers, and pharmacy service administrative organizations. Today, we are going to be really focusing on the health carrier component of the Drug Price Transparency Program. So if you're representing one of the other submitter types, we won't be really addressing information that might be pertinent to you, but you're more than happy to ask questions and listen in. So next slide. So the legislative findings for this program was the price and cost of prescription drugs that has been increasing over time. Also, the legislature wanted to provide notice and disclosure of information relating to cost and pricing, and to really provide accountability to the state and purchasers within the state around prescription drug pricing. Again, it was due to rising drug costs, which was impacting consumers' ability to access their medications, and then also trying to control the overall expenditure on drugs for state purchasers. So next slide. So I have some definitions to go over. The health carrier or carrier It's the same that was listed in the RCW. It's a disability insurer regulated under Chapter 4820, 4821. Other health service contractors as defined in Chapter 4844, 010, and 4846, 020. And then health plans are defined, and health benefit plans are defined. I'm not going to read this to you. And we really want to encourage other health plans that are regulated under the federal rules, so like Taft-Hartley or ERISA plans, those self-funded insurers, to submit their data voluntarily. Next slide, please. So the definition of a prescription drug that was in the statute was a drug that was regulated under Chapter 6941 or 6950, including generic, brand name, specialty drugs, and biologic products. So getting into kind of the meat of the reporting requirements, the statute said that health carriers are to submit annual data to the healthcare authority, and it was cost and utilization data, including the top 25 most frequently prescribed drugs by providers, the top 25 costliest drugs as a percentage of the total planned prescription drug spending, and then the top 25 drugs with the highest year-over-year price increase. Additional reporting was to report the portion of the premium that is attributable to each category of drug, and those drug categories were defined as brand, generic, and specialty. It asks to report the year-over-year increase in the total annual cost of each category as a percentage and calculation of the per member per month calculation. And number 5, a comparison of the year-over-year increases in the cost of covered drugs as a calculation of the per member per month compared to a year-over-year increase in the cost of other contributions to premiums. So next slide. In addition, carriers are to report the name of each specialty drug, and we're going to ask for that by the NDC number, and the top 25 drugs in which the issuer received rebates from manufacturers. HCA then is required to take all that data and synthesize it. So we are collecting the data, we'll analyze it, and then we are to prepare an annual report that will be published on our website that looks at the overall impact that drug costs and rebates have on the overall cost of care. Next slide, yeah.
So I'm sorry, is that the right one? I hit the
No,
mouse.
you need to go forward. You were one more. That one right there.
Thank you.
So we will prepare an annual report for the public, posted on the website, that demonstrates the impact of the drug prices and costs on the overall healthcare premium. In addition, HCA was directed to make a recommendation on how to provide advance notice of price increases for drugs to other purchasers in Washington State. The statute also allows the healthcare authority to assess a fine of up to $1,000 per day for failure to comply with the requirements. So we're going to ask you some questions about what a fair enforcement program might look like. The enforcement goes into the Medicaid fraud and penalty account. So we will be creating a process to enforce compliance with the issue with this particular statute, and that we'll be doing through our rulemaking process. And we are developing, we're also developing ways that we would collect the any fines that would be assessed to the carriers or other submitters through the rulemaking process. And So we have some key components for the implementation of the program. So we have the communication, which is communicating with interested stakeholders on the progress of the program or the project itself. We are doing rulemaking, which is being led by Annette and her team. There's stakeholdering, so we're holding 3 listening sessions we've had the drug manufacturers listening session already, today the carriers, and then later in April we'll be having a listening session with pharmacy benefit managers as well as the pharmacy services administrative organizations. We'll be looking at compliance. What does that look like? We're setting up a data infrastructure to collect the data, have the submitter submit the data, we'll collect it, store it. We providing governance around the data to make sure that it's only disclosed to those that need to see it. We'll be doing data analytics, and then also coming up with data definitions and specifications for submitters to submit the data to us. And then of course the annual report that I already mentioned will be posting on the website in January. Next slide. So Annette, I don't know if are you back on? I'm not hearing Annette, so I'll let her, I'll just keep going.
Can you hear me?
Oh, I can hear you.
Can you hear me?
Yes.
Am I echoing?
No.
Yes, I'm back on. Welcome. I'm so glad everybody stuck with us and stayed with the presentation. I am so sorry. Webinar is not the method that we had preferred to do a listening session. And I really wanted to meet you in person. This is our rulemaking schedule. Again, my name is Annette Scheffenhauer. I'm Washington State Healthcare Authority's legal director, and I oversee the regulatory processes of our agency. We've already filed and initiated the beginning of the rulemaking process. It was filed in Register 2003. We are working on a draft rule right now. We should have external review available of that rule prior to the CR 102 filing in July. So between May and June, we're going to be pushing out to you those draft rules for your early comments and feedback. The scheduled filing date for the CR 102 is on that July 22nd with a public hearing date on August 25th. With the public hearing, you'll be able to submit written comments or come testify in person. We really want to hear your feedback. And then the rule will become effective on October 16th. Next slide. So our tentative program schedule, we are working on finalizing a list of contacts with the organizations, sending welcome letters, sending definitions out to all of our stakeholders for comments and reviews, as well as a draft submission guide with instructions, working on collecting data and troubleshooting data collection processes, and implementing a process, the enforcement process. What do we do if people don't submit? And then working on the analysis and reporting. So that's what we're doing. Next slide. And Donna was going to take us through some listening session questions. These are the prompt questions that we shared with you in advance of today's webinar. Really, we wanted to hear your feedback and perspectives on some of these questions we had. And then we really want to hear your feedback on stuff we didn't ask about. Tell us, what that we might be missing, right? So Donna's going to take you through these questions, and Lita's going to help facilitate the process. Donna, go ahead and take it over.
Great, thanks, Annette. So we've talked a little bit about the enforcement process. So we want to hear from you. What do you feel would be a fair enforcement process? So something to think about, is it the first time you don't submit or you submit late that you might be fined? Should there be a grace period of you're trying to get your data in, you're having technical difficulty? What do you feel would be a fair enforcement process, or what would you be looking for as a submitter if you were having difficulty? So Annette, I'm going to turn to you. Just, is there anything else that you were thinking about with the enforcement process that you would want to hear about?
Anything that the, people would like to share with us. We're creating an enforcement process anew. We recently took over the All Payers Claim database, which has similar data collection enforcement processes. We're trying to figure out the best way to create a really good process to administer the program. So just really interested in what the end user has to say about that.
So there's no questions from attendees yet. So why don't we read through all of the questions, and then I have two written that we can go over first.
Okay. So the next question, can you go back to slide 16, Lita? So the next section is, are there other states in the country that are doing a similar drug price transparency program for carriers? And are there states that are doing that well that we should potentially take a look at what they're doing and try to model after that particular state? Okay, and then the next question is, what do you need from the healthcare authority to successfully provide the required information and data? So our plan is to come up with a set of data definitions, example like the top 25 drugs, and we'll talk about those in a minute, and give you specific requirements to submit the data. Is there anything in particular that you feel you would need in order to submit to us? Okay, and the next question, what should HCA consider while developing its infrastructure? So some states that we have looked at have an online portal where you submit the data through an online portal. Other states might be collecting the data through an SFTP site where you might just be uploading files. Is there anything in particular that we should try to keep in mind from the submitter's point of view when we're trying to set up a conduit to collect this type of information?
Hi, Donna. I have one question from Merlene Converse. Can you tell us when the first submission would be due?
So the first submissions are going to be due October 1st of 2020.
Okay, and then Eleanor Shinsky asked, or stated, California has the same report. I also had a question from Lugina Mendez Harper saying the slide deck being used today is different than the slide deck sent out several weeks ago. So I did send out this slide deck on Monday saying that we added some questions, and it is also on our website. Eleanor Shinsky also has said California's report is due on October 1st of each year.
Great, thank you. So one of the questions, one of the directives to the healthcare authority from the drug manufacturer side, we are required to collect, the manufacturers are required to report to us when they are going to increase the cost or price of one of their drugs. And the legislation then says to the healthcare authority, come up with a recommendation on how to provide advance notice of these price increases to purchasers. So as purchasers on the phone, how would you, if it were you that were having to provide these advance notices, how would you recommend that we provide those notices to you?
Okay, Donna, I'm going to stop you there. I have two more. Skylar Majobian asked, will HCA be considering existing plan capabilities as far as data transmissions?
I think if you can provide to us, a little bit more detail with what those capabilities or limitations might be, we would definitely take that into consideration while we're trying to develop our infrastructure. That was one of the items that we have heard from other states, is that certain companies or organizations have different technology capabilities. So we do want to try to keep that in mind. But we really need to get a good sense of what those challenges or limitations might be.
Okay, and Michelle Bice said that Oregon also has a report published fourth quarter 2019. Should we move on to the next question page?
Yes, let's move on to the next question page, Donna, and then we can open it up for individuals to raise their hand if they want to provide comments on any of the questions that we pose.
Great, thank you. Thanks, Annette. So now I wanted to get into some more detailed questions, and it sounds pretty straightforward when you say report the top 25 drugs. However, if you've looked into drugs and how the claims are billed, you'll know that the top 25 drugs, how are you going to define that? So some states are asking for the top 25 NDC numbers, which is the National Drug Code. We feel that's too broad, that it doesn't really capture the entire expenditure for a drug. So what we are looking at is defining the top 25 drugs at their ingredient level. An example might be, if you have fluoxetine, any drug that the primary, the ingredient is fluoxetine, we would expect you to report all NDC numbers for fluoxetine and roll them up to a single drug. So I wanted to get some feedback from anybody on the phone about have you thought about defining top 25 drugs, and what would be a meaningful way to do that?
Okay, so I have one hand raised and I have two more comments. First, I'm going to read these comments. Sarah Kwiatkowski said, to provide notice, you could model something like the APCD, where carriers provide HCA with a single point of contact to receive information on advance notice. Eleanor Shinsky asked, will the filings need to reconcile to any particular filing, possibly the NAIC Supplemental Healthcare Exhibit or HHS's MLR report? If they do, we will be able to provide you with the case levels file for the state of Washington. Okay, I'm going to unmute Skylar. Okay, Skylar, if you want to go ahead and speak.
Hi there, can you hear me?
Yes.
So the one comment that we are hearing from our pharmacy folks as far as the definition of the top 25 is that defining it by the ingredient level may be a little bit confusing, and we are hoping to kind of get maybe a little bit more explanation or examples and the proper way to do that, just so we make sure that we capture everything that should be included in the report.
Okay, and Skylar, can I ask what organization you represent?
Oh, yes, I'm sorry. I am from Primera Blue Cross.
Okay, thank you.
Hey, Skylar. That's a great question. It's something that we grappled with. I would love to be able to say, report it by the GPI number with, but those are proprietary numbers. or proprietary information. We're trying to, and I do believe, Lita, if you actually go to the next slide, we might have an example. So this is an example of the top 25 drugs. So we would say, if you're looking at the ingredient name, I know that however the manufacturer lists their name might be different. So you might have, here's my example, 3 different ways that the ingredient name is listed at the drug level. We would roll them all up to one NDC or one particular drug name. So,
Okay.
And you know, I used it. This is probably more more of a challenge when we're looking at generic drugs rather than brand name drugs. However, with brand name drugs, you know, you have like Humira, Humira Pen, Humira this, Humira that, but they're all Humira, and so we want that all to count as a single drug. Once we get all of those NDCs, we're able to then get into more granular analysis. We can link it to our own internal drug reference table as well. But what we're trying to do is capture as much information as we possibly can to attribute towards a top 25 drug.
Okay, thanks.
And
I'll take that back to the pharmacy folks, and I appreciate the explanation.
And can you go back to the previous slide, Lita?
Yeah, and I have another hand raised, Eleanor Shinsky. I'm going to unmute you now.
I'm sorry, I just wanted to ask the question that you asked earlier, so you can mute me again.
Okay, thank you. And I have another person here. Hang on just a second. Okay, Shay Wilson, I'm going to unmute you.
Hey, Donna the Shay, long time. You know, the definition of top 25 is a difficult thing for many of the reasons that you've alluded to, but also is the top 25 that are utilized. So the number of claims is very different from the top 25 based on cost, because sometimes cost, very, very expensive drugs can filter to the top of that list when it's only got 1 or 2 claims. So in confounders in here, I do like the way you put in fluoxetine. It does work, but always, you know, what's utilization and what's cost. I think that those are the two distinguishers that I like to have used, if that's possible.
Right, and Shay, the legislation asks actually we have to get both of those lists. So what we'll be looking at is, you know, we'll ask you to look at the ingredient name, roll them all up, and then determine by cost what is the top 25 drugs. And then when you've rolled up all those ingredient names by the number of claims, what are the top 25 drugs? And so it's really just the concept of how we're defining what a drug is, knowing that there's multiple products out there. Yeah.
And not to consume all the time here, because you and I could talk about this for an hour, but things that are brand generic, I'll roll into the generic, the active ingredient name. Is that accurate?
Mm-hmm. Yeah, and we, this is really just a single piece. If you actually look at we'll be asking for you to roll up the drugs into a single drug line for determining what is the top 25 of either utilization or cost. But we're going to ask you to report out on every NDC number that goes into that one ingredient name. And so you will be reporting brand and generic information independently of one another. So we'll be able to look to see what's a brand and what's a generic and break that out. But yes, they would roll up into the same number, the same drug line when we're calculating the top 25.
Okay. And quantities for those NDCs or just NDC numbers?
I think at this point in time, we're only asking for NDC's label name. I think I'm not sure if it was sent out, Lita, or not. We had a draft definitions document that we will share with you. Yeah, go ahead. we're looking at the label name, generic name, number of claims. I don't think we're going to ask, I forget if we were going to ask for the unit amount, the unit quantity dispensed or not. But we do have, we're trying to come up with the data elements as well as what that information would look at. So we were looking at day supply, units, claims. I think by the NDC.
Okay.
So we could go back
Looks
to
like
the slide deck.
Okay. And I have 2 more comments here. Just a second.
Yeah, I see Adam's question about date. Yeah, so Adam, that's a great suggestion. Looking at the number of claims, it might be better to look at number of days supply that were dispensed because a claim could be a 90-day supply rather than a 30-day supply. So thank you for the input.
And let's read his question. So Adam Binder asked, should claims be weighted based on day supply? For example, 90-day supply equals 3 30-day supplies. Okay.
Right.
Okay.
Go ahead.
The next question is from Lugina Menzer Harper. Are the reporting fields being shown on the screen matched to NCPDP fields?
No, that's a great question. And thanks for the feedback, because I think that that's a good idea since we are talking about claims. So I don't think we talked about it in that regard, but that's a great suggestion. So thank you.
Okay,
So
I have no other questions right now, so if you want to continue.
Sure. So we've had discussions on whether or not this should include physician-administered drugs or not. So go back to the previous slide.
Yeah.
Physician-administered drugs. And the statute itself says that these are covered drugs that are dispensed in the retail setting, that they're used for outpatient and dispensed in the retail setting. So we're having some internal conversations about, how to treat physician-administered drugs, because those are high-cost drugs that probably might have just as much impact on a premium for a health plan as a drug that would be dispensed to the patient from a community pharmacy that they would take at home. So any feedback on physician administered drugs and in or out?
I have a hand raised. Karen Swenson Moore, I'm going to unmute you.
Hi, Donna. This is Karen Swenson Moore from Regents. I'll put in a plug for being careful with physician administered drugs, because depending on how they were purchased, we may not have the level of detailed data needed. They are coded pretty differently in the claims system. And if, most of us work with PBMs, and the PBM would not have that data that would be coming through the medical claim.
Okay, thank you. That's good feedback. Okay, so the next one, so when the legislation also speaks to reporting drug costs compared to overall healthcare costs. And so what we want is for the carriers to report the data in the same manner. So we break it into hospital, inpatient hospital, outpatient hospital, emergency department, professional and other, pharmacy expenditures. Is there a standard definition for these types or segments of the overall healthcare expenditures that we should be using or requesting this the information to be reported as?
Donna, I have a question from Vicky Kidd. Should the top 25 costliest be based on the total claim price or the portion the plan paid?
So this is Donna. Yeah, I think where we are landing on is going to be the total allowed amount for that particular drug. And we will provide that type of direction explicitly in the submission guide, so you'll be able to define. It should be pretty clear on how to calculate and which costs we're looking at. So any feedback on the overall healthcare costs and how to break those out?
I do not have any hands raised.
Okay. And then what we wanted to ask was, do you have any concerns providing the healthcare authority with member months? We'll need to collect member months in order to look at PMPM impacts that the plans or that the legislation required. Also looking to collect days supply, units dispensed, and information regarding the rebates invoiced and collected.
Okay, I have a hand raised. Okay, from Shay Wilson. Go ahead, Shay, you are unmuted.
Thank you. On the units dispensed, you mean some specialty drugs or high-cost injectables have units of the dose comes in units. So, you know, the prescription would come as you need this drug, but this is the dose you need, and we break it down by units. Or is a unit a pill, tablet, capsule, or is a unit a milliliter, a syringe size? That part gets real challenging, and you know the rebates part is always challenging because it comes 9 to 12 months after the fact.
Right. So we did have some of that conversation about when you're talking about units, are you talking about billable units, rebatable units?
Yeah.
You know, the package size, if you're distributing a whole package. What we will probably land on is the billable unit. And to some extent, we might need to ask for what the rebatable unit is as well, if we're asking for the rebates, so that we can do some sort of comparison to those. We have those issues as well, where the package size might be 12 grams, but the rebatable unit is 1 because it's 1 package.
Yep, it gets messy.
Okay, Karen Swenson Moore has her hand raised. I'm going to unmute you.
Hello. So that gets into a question we had talked about around lines of business to be included. And in particular for large group, not all large groups have their medical and drug bundled with the same administrator or the same carrier. So have you thought hard about, you know, are we just talking about insured business and only those for which, you know, medical and drug are bundled under the same carrier? And then as far as breaking out and reporting overall costs, you might want to start really simple with this. I would encourage you to not get overly complicated up front, because you can always add stuff later.
Okay. Great feedback. So when you're talking about large groups, are you talking more about large employer groups that might be self-insured?
Generally, yes, but I won't. There's got to be exceptions out there. Somebody's probably got an insured group that's carved out their pharmacy separately from their medical.
Okay, so great question, and lots of more fun for us to figure out how to do that. So thanks for that feedback, because I wasn't thinking that insured groups would have carved out benefits, but we will definitely need to consider how to address those particular programs.
Hey, Donna, I have a comment from Lugina Mendez Harper. Rebates occur post-adjudication and post-utilization. Has HCA given thought to how to provide guidance to carriers and PBMs for reporting rebates, knowing those data fields very well after use and perhaps even after reporting to HCA?
Great comment. So that's why I was, asking for concerns or comments related to the rebates, and realizing that, we invoice rebates typically quarterly, and the collection is what is the delayed piece. So we haven't really considered, how to collect that particular rebate information. It could be that we have some sort of lag report where each year you would update the previous year's collected rebates. And then, after a year, 2 years, we would expect, those rebates to be pretty baked, and they're not going to change too much more.
Donna, should I bring up the written questions at this time?
Did we get through all the ones on our slides?
Yeah, then that goes back to the top 25.
Okay, and then, so is the next slide just the question, a general? Yeah. Okay, that's the
for rulemaking, so we'll come back to that. So we had 2 written. Hang on just a second. Okay, so I will start here. This is from Primera Blue Cross, from Skylar, who is also on the phone. So how do you define the top 25 drugs? Top 25 covered pharmacy benefit drugs within the previous calendar year based on cost. How do you define prescription drug, federal legend drugs, or over-the-counter drugs covered under the pharmacy benefit as required by ACA or state level mandates? Should we include physician-administered drugs in the data submission requirements? No, Primera would not be supportive of including physician-administered drugs. The claim format is different, and this requirement would drive errors by adding undue complexity to the reporting. What do you need from HCA to successfully provide the required information and data? Primera requests that HCA define the format if a specific format is required, and method of submission in addition to providing a data dictionary. We also will request that HCA clarify if the date range is based on the date of service. What should HCA consider while developing its infrastructure? HCA should consider existing plan capabilities in order to promote efficiency. We encourage HCA to partner with carriers to ensure that requirements are clear and not overly burdensome for either the carriers or HCA. Donna, did you have any comments on any of this?
No, I actually appreciate the feedback, especially the date of service. I think we will probably look at date of service. It's always challenging with paid date because it could be 2 weeks. It could be different from the date of service, and we'll definitely take that into consideration when we're collecting that information. As far as the capabilities, so that's the technological capabilities. It would be interesting to know what are your preferences? Is your preference like an Excel spreadsheet or some sort of flat data file that you can just transmit to us like via secure email or an SFTP site? Is the preferred method, some sort of online portal? What are you thinking about? It sounds like you have experience with other programs, maybe not a drug price transparency program, but what are other programs where they've asked for data that have caused questions or caused concerns?
And Skylar, I can unmute you if you had any follow-up comments.
Hi, can you guys hear me?
Yes.
Great. So, I think we'll have to take that question back and really get to kind of what format would be, what the capabilities are. In the past, I believe mostly data transfers happen through Excel, SFTP, but that's the extent of the information that I have now. But, I appreciate you taking into consideration the carrier capabilities, and we will certainly kind of follow up with you on that.
Okay, great.
Okay, I'm going to pull up another letter here. Okay, and this is from Kaiser Permanente. Okay, so the first is about the RCW requires a health carrier to submit the requisite data for each health plan it offers in the state. We would appreciate clarity on this requirement, in particular whether the HCA will require separate data submissions for each and every health benefit plan offered by a health carrier, or whether the health carrier will be permitted to make one data submission for all health plans within the scope of these reporting requirements. We would recommend the latter approach to streamline this process and reduce the complexity of the data submission. Donna, do you?
Is there, I don't know if there's the Kaiser person on the phone. I think what the challenge is, what I'm not sure if they're asking is one report for all books of business where you don't have the different books of business or the different health plans identified, or one file that includes all of the data, but we have the individual plan identifiers within the data. So that instead of giving us 50 files for 50 health plans, you give us one file that includes all 50 health plans, that we are able to identify the individual health plans within that one carrier. What the legislation does specify by health plan, and it does say impact on premiums, and it also asks for per member per month. So I do believe we need the individual health plan level detailed data in order to get to that level of analysis that the legislature is looking for.
Okay, I see Merlene on, so I'm going to unmute you, Merlene, in case you want to follow up. And also Simon, I will also unmute you. Okay, you can.
Hi, this is Simon. Can you hear me?
Yes.
Yeah, I think our clarity was more around the fact that, just for an example, in our individual business, we have multiple different plans with all different, variations of benefits, deductibles. And so kind of calculating all these elements for each plan and making a submission for each plan would obviously not be preferred. I understand we need to have the data for all these relevant lines of business that are within scope. And so just kind of getting clarity on that fact, I think, is what we're looking at.
Okay. So I think at this point in our planning, it would be at the individual plan level.
Okay, so the next paragraph Okay, I'm gonna mute you guys for a minute because of the feedback. Okay. Okay, so we know the health plans offered by self-funded employer groups are not required to submit data. However, we would like confirmation on whether these data reporting requirements apply to Medicare Advantage plans and federal employee health benefit plans.
So hi, Lita. That's a great question. I don't think we're prepared to provide a response to that right now, but we will definitely take that into consideration and make sure that we clarify how those programs should be handled.
Okay, the RCW also requires health carriers to submit the requisite data for the previous calendar year. Due to the delayed implementation timeline for data reporting, which initially required health carriers to submit 2018 data, are health carriers now expected to submit 2019 data for the first submission due in 2020. Additionally, when classifying prescription drug data for purposes of the reporting year, we recommend and plan to classify prescriptions based on their fill date.
I think the second part of that statement question, we based on the fill date, I think that we're probably in agreement on that particular piece. I don't think we have nailed down exactly which calendar years of data that we'll be asking for the first submission. So I'm not really ready to respond to that, but we will be getting that to, it'll be clearly stated in the submission guide of what the data span should be for the submission.
Okay, for the various reporting elements that require providing the name of specific prescription drugs, we request the HCA provide more clarity about how health carriers are expected to classify a prescription drug. For example, notwithstanding the definition provided in RCW, are health carriers classifying prescription drugs broadly to include all dosages of a particular drug or all prescription drugs in a particular class or therapeutic category, irrespective of manufacturer?
And I think we talked about that already, so I'm not going to provide any feedback on that. And I think that the next paragraph we've also commented on.
Okay.
So I think we can go down to.
Okay. Okay, RCW requires health carriers to report the 25 most frequently prescribed drugs by providers in the health plans network. We recommend and intend to report this information based on the total number of fills for a prescription drug, as health carriers are not able to track how many prescriptions are written by providers. Often providers may write a prescription that never gets filled by the enrollee, and the health carrier would have no way of tracking this data.
And I think that the way that the legislation was written was probably was considering the total paid claims. So we'll be looking at paid claims, not the number of, trying to capture what's written versus what is actually taken to the pharmacy and filled.
Okay, RCW 4, 6, and 8 make reference to rebates and discounts. We suggest the HCA define these terms or provide guidance on how health carriers should account for discount and rebates. When some health carriers receive volume discounts or lump sum discounts not attributed to one particular prescription drug.
Yeah, so we'll have to take that into consideration in our definition. Thank you for providing that feedback.
Okay, RCW 4 and 7 make reference to specialty drugs. How does the HCA define specialty drugs? The Medicare Part D program classifies the specialty drug tier as drugs that cost more than $670 for a 30-day fill. This could serve as an easy threshold for HCA to use. Additionally, RCW 4A references brand name drugs. How does the HCA tend to define this term, and how should health carriers classify drugs that might fall into multiple categories? For example, brand name, specialty, and biosimilars.
So what we were considering was, when you report the data to us, would be to indicate whether or not you considered that to be a brand, generic, or specialty drug. And then we'll be asking for, a list of your specialty drugs to be submitted as well. So we recognize the challenge of trying to define specialty drugs. I believe the Medicare definition is that price point is far too low. And then everything becomes a specialty drug based on cost. So we'll be looking for the carriers to provide how they're determining what is a specialty drug and specifically identifying what specialty. And we will also be asking, like, if you're using First Data Bank or Medispan, what is your source of determining what's a brand or what's a generic? On some of the traditional drugs, sometimes it's not straightforward, and it could differ from one drug reference table to another. So we want to be able to try to compare apples to apples.
Okay, when calculating the year-over-year increases in the price of covered drugs as provided in RCW 5 and 6, are health carriers expected to base this data on wholesale acquisition costs similar to what is required in RCW 3?
That's another great question, and I don't think we've quite gotten that piece hammered out. So the question could be, is it the cost increase of the drug, or is it, an increase in expenditure, which could be a combination of utilization as well as price increases. So we are working through our definitions, and I'm not quite sure we've gotten to that particular item. So it would be, your feedback on what you interpret that to be would be very helpful.
Okay, Karen Swenson-Moore has her hand raised. I'm going to unmute her now. Go ahead, Karen.
Thank you. Just a comment again regarding specialty drugs. If you want meaningful data, I think I would recommend that you define what you want in those categories for a couple of reasons. Number one, specialty drug lists change all the time, even within a carrier, and they're not consistent for every benefit plan and every line of business within a carrier, and they vary by benefit offering also. So I just think unless you define it pretty carefully, how, what drugs you want where in a given time period, and you're probably going to have to revisit it every time or every year or something. If you want something that you can actually draw some conclusions from, you're going to have to define that. Because there's things going on in the marketplace around, the generic versus brand, let alone specialty, how broad or narrow the specialty list is. And then, if it's a triple source generic, if there's multiple or brand, does that make it a generic or not? There's drugs that could fall in either category depending on how they're being defined by that particular plan. And we have, every carrier that's doing this these days is going to have a variety of options depending on the customer, the line of business, et cetera.
Right. And Karen, to your point, we subscribe to both First Data Bank and Medispan. So to get the data, the way that we're looking at reporting the data is to tell, when you report the data, whether or not you consider that a brand or a generic. I don't think we would say, what was your total spend on generics? If, I'd have to go back and look at the statute to see if that's one of the items we do need to look at. And I actually think it was one of the ones that we do need to break out into the buckets. It becomes challenging for us to define those without giving you a list of NDCs and saying, each one of the, and saying this is how you should report each of these drugs.
And I'm just saying that we don't, within our company, just by us as one example, we don't have a single specialty list.
Right, but each plan has its own, has a specialty list, right?
And what do you mean by plan? You mean carrier or
a group? So let's say you have one plan, that has a small.
That works for individual and small group. On large group, it's much more customized by group. Really 51 plus employers, we start having a whole lot of variation. So it's just more complicated. It's not saying we can't do it. I'm just wanting, at the end of the day, this reporting to be something that's actually useful for the state. So just something to think about.
Sure, thank you.
Okay, well, I don't have any other hands raised. Annette, are you on the line?
I am. Can you hear me?
Yes.
Great. So today's session was to provide you guys a little bit of information, stuff that you could read just by reading, some of the past laws. We hope that we were able to provide you some information about the things that we're working on to implement this program for an October 1st date. And really what we were hoping to get out of it was information from you to help us make sure that we set up a program that works in a way that you can report the data that you need to be in compliance with law. So I wanted to pause and give folks a chance first here to listen. And so if there's other stuff you want to share with us today that you think would be great for the Healthcare Authority to take into consideration as it's working on its draft rules, as it's working on its submission guides, now's a great opportunity for you to send us a message or raise your hand. And I'm going to pause for just a moment to see if anybody else has anything that they would like to offer up.
So, and I just wanted to point out that the rulemaking process and notifications is a completely separate communication tool. So if you specifically want rulemaking notices, you do have to sign up for those notifications. If you're being signed up for the Gov delivery for this particular project and program, will not get you those rulemaking notifications. So those are two separate logins that you'll notifications that you'll have to sign up for.
It's a great point, Donna. And it's really easy to do. Just go to the link that's on the slide deck, and you can go ahead and sign up for getting the rulemaking notices. We're on a pretty tight schedule for the rulemaking, so there won't be any delays on our side for that process, but we want to make sure that you guys get the information as soon as possible, especially the external review draft that happens before the public hearing, which is a great opportunity to influence in addition to these forums.
Okay, and Skylar asked, will these slides be available after the meeting? And they are already posted on our website. If you go under the April 1st meeting, this is the presentation. Also, the data definitions PDF that I put on the screen briefly before, I'm going to send that out tomorrow to all of the stakeholder groups so you can have input on that.
And Lita, we can post that on the website as well. And I believe, do we have a mailbox, an email box?
Yes, yes, it's on this next slide here.
Okay, great. So if there's any additional questions, or if you have other feedback to provide, send it to the drug transparency at hca.wa.gov email box. we might not reply to every email that we get, but we'll definitely take all of your feedback into consideration as we are trying to set up this program.
Donna, this is Mary Fliss. I just wanted to add one more comment, and that is I heard a lot of questions and sort of alternatives around how to define specialty drugs. And I think that if folks on this call have ideas and certainly heard the alternative of aligning that definition to Medicare's definition, if there are other alternatives for us to consider in terms of that definition, it would be very helpful to hear from you. And you can just reply to this email address.
Thanks, Mary.
Okay, I'm not seeing any other questions or raised hands. All right.
All
Well,
right, thank you, Lita.
okay, yeah, I was just going to say we can wrap up the meeting, and we look forward to hearing from you guys.
Yeah, thank you everybody for attending and bearing with us through our technical difficulties, and we look forward to receiving more feedback from you. So have a good rest of your afternoon.
Thank you, everybody.
Thank you.
Thank you.